Hello, everybody. Welcome to the launch of the London School of Economics Lancet Commission on the future of the NHS. My name is Richard Horton and I'm the editor of the Lancet. Today we're marking, even celebrating, two important firsts. It's the very first time the Lancet in its 200-year history has dedicated such a substantial piece of work to the health system of the country in which we were founded. You can see that either as an astonishing omission or as an extraordinary opportunity. And the second first is that it's the very first time that we have partnered with the London School of Economics. It's a partnership that is long overdue. These firsts are not only symbolically important, they are substantively important too. Despite what we always see, the intense political debate about the National Health Service, the sad truth is that governments, public, even the health professions, and certainly medical journals too often take the NHS for granted. We're very proud of its creation. We acknowledge its importance as an emblem of national solidarity, but we too often fail to face up to its imperfections and its frailties. As if to point out those imperfections and frailties is somehow to betray our commitment to the cause of the NHS, its values and its philosophy. But we need to confront those limitations and deficiencies exactly because we are so committed to the ideas that the NHS embodies. And our partnership with the London School of Economics is profoundly meaningful too. Typically, we in the health community work with academic medical centres or specialist health institutions, and we're very glad to do so. But the danger of that intellectual bias, because that is what it is that we don't submit our assumptions or our evidence to broader disciplinary scrutiny. And the LSE has provided the absolutely ideal institutional home for this commission. And I'm profoundly grateful to Elias, to Alistair, to Emma, and to Michael, and for their superlative leadership, and of course, the contributions of commissioners. The COVID-19 syndemic has revealed both the value and the defects of our national health, public health, and social care systems. And it's emphasized the intrinsic importance of the research system to patient and public care. The syndemic has also moved those who are usually marginal, excluded, or even invisible in our national conversation to the very center of the political stage. It's really shown who the key workers in our society are. And the pandemic, the syndemic, has uncovered the hidden vulnerabilities of our fellow citizens across the life course. So although it is an omission that the Lancet hasn't made the NHS a central concern in the past, thanks to our friends at the LSE and our commissioners, we collectively do now have an opportunity to redefine the role and the purpose of health and well-being in our national culture, our national conversation, and the part that the NHS, public health and social care play in sustaining that health and well-being. And we also have the opportunity, very importantly, to share these lessons with countries grappling with some of the same predicaments that we face. So let me now hand over to my friend and colleague in arms here. Elias, it's great to see you, and you take over the show.
Yeah, thank you, Richard, for your very kind words. I'm very excited to see how many people have joined us today as we seek to stimulate discussion and debate regarding how we can strengthen our NHS in a post-COVID-19 world. Alistair, Emma, Michael, and I would like to express our thanks to the commissioners and to the Lancet editors Richard, Astrid, and Naomi, whose guidance and direction have been crucial in the development and framing of our report. The UK was an early adopter of universal healthcare, providing a high level of financial protection and facilitating the redistribution of resources between the rich and the poor. However, as Richard emphasized, inequalities in health and in access to health services are a persistent problem. Brian Abel-Smith had expressed concerns about these factors in the 50s, well before they became a key policy issue in the mid-70s. To add to this, the NHS has a number of enduring weaknesses related to aspects such as funding, health outcomes, workforce, use of data, and integration of services. We outline a series of recommendations and actions to map out a strategy for our NHS to deliver a world-class healthcare service that is reflective of our country's position as the 5th biggest economy in the world. I would like to begin this launch event with our pre-recorded presentation, which provides more details regarding the scope and main findings of our commission. This will be followed by presentations by commissioners on specific recommendations and panels reflecting the perspectives of the devolved administrations. We're also fortunate to have reflections on the report from Nigel Edwards, Chief Executive of the Nuffield Trust, and our LSE colleague, Professor Julia Legrand, former Senior Policy Advisor to the Prime Minister.
So welcome, and now we want to give an overview of the Commission findings. Launched in late 2017, the LSE-Lancet Commission provides an analysis of the main opportunities and challenges facing the NHS, identified before the pandemic, as well as critically considering the COVID-19 response to date. In doing so, we acknowledge the many strengths of the NHS and draw systematically on evidence across the 4 countries and internationally. Using our analysis, as well as recommendations from previous studies, we identify a series of targeted recommendations looking to 2030 and beyond. And crucially, we outline bodies, organizations, ministries that are responsible for implementation. 2030 may sound a bit off into the future, but of course, some students entering medical school this year will be in their first posts. As discussion and analysis of the COVID-19 response continues, our Commission report is the first to provide this within a long-term analysis of the NHS. Hence our chosen title for our Commission, Relaying the Foundations of an Equitable and Efficient Healthcare Service in a Post-COVID-19 World.
The Commission has been a truly collaborative effort, chaired by myself and Alistair Maguire, and involving a diverse group of over 25 commissioners who were selected to ensure representation from the UK constituent countries and a range of disciplinary backgrounds to reflect experience within the NHS and knowledge of healthcare systems outside the United Kingdom. We are truly grateful for the efforts of everyone over the last 3 years, a crucial time in NHS history, which began with a period of reflection prompted by the 70th anniversary of the NHS and was followed by the biggest public health crisis in the history of our health system. This has provided an invaluable opportunity to assess the enduring strengths and weaknesses of the NHS.
As part of our analysis of the NHS, we undertook stakeholder consultations across all of the UK countries. We used 3 main approaches for this: an open call for evidence, an evidence hearing, and targeted meetings in London, Cardiff, Belfast, and Edinburgh. We had a broad range of stakeholders who responded, including the government, professional bodies, trade unions, royal colleges, and patient organisations. And we want to express our gratitude to everybody who contributed to this process, and we have endeavoured to ensure that your perspective is represented throughout our report.
The UK experience during the COVID-19 pandemic has emphasized not just weaknesses, but also many enduring strengths of the health and care system, which are outlined within our Commission report. First and foremost, many aspects of the NHS response warrant commendation, such as the national vaccination programme, willingness of the workforce to adapt in unprecedented challenges, and implementation of system-level changes, such as expanding critical care services and the rapid increase in the uptake of remote consultations to prevent transmission of coronavirus. Another major strength of the NHS is that it continues to provide citizens with a high level of protection from the financial consequences of poor health, with some of the lowest incidences of catastrophic expenditure due to out-of-pocket health spending in the world. This is predominantly because a fundamental principle of the NHS is that access is based on clinical need, not on ability to pay. The result is that the distribution of resources is generally poverty reducing, with a few exceptions. This is important as the UK has higher levels of income inequality than most other high-income countries. In some respects, the health system can be considered an island of universalism, operating within a poorly functioning welfare state, evidenced by higher levels of income inequality than many other high-income countries.
So this slide covers a number of other aspects of the strengths of the NHS. Over several decades, each country within the UK has developed fairly centralised and systematic national level resource allocation mechanisms. These are used by local authorities such as clinical commissioning groups or health boards based upon estimated population health needs, which has the dual benefits of financial control and considerations of equity and access. In terms of health technology assessment, this is spearheaded by organisations such as the National Institute for Clinical and Social Care Excellence, NICE, and the UK has also led the world in terms of developing the methods of healthcare technology assessment and benefits from a methodologically robust and transparent system for the evaluation of pharmaceuticals and new technologies. In terms of chronic disease outcomes, despite performing poorly in terms of a number of these health outcomes, the NHS performs very well in terms of outcomes for certain chronic diseases, for example, diabetes and kidney disease. This is in part attributable to a strong primary healthcare system. Also within the UK, research and innovation has a long, well-established history of being world-leading. Recently, it was highlighted, of course, by the establishment of world-leading clinical trials on vaccines and treatments for COVID-19.
The UK has experienced one of the highest death rates related to COVID-19 in the world. From the NHS perspective, limited access capacity, poor supply of personal protective equipment, initial limited capacity for testing, and erosion of public health capacity, and barriers to integrating data have all impeded our response to the pandemic. The limited capacity has happened in part because over the last 30 years, the UK has had consistently lower public spending on health than most other high-income countries. For social care, the situation in terms of funding is worse. At a time of increasing need, spending on social care has reduced in real terms, and again, is also lower than in most other high-income countries.
In terms of the workforce, the UK has fewer nurses and physicians per head of the population than many other comparable high-income countries. Moreover, a lack of strategic direction and ineffective workforce planning has resulted in a failure to adapt the skill mix to respond to changing health needs and significant and persistent shortfalls in staffing. At the local level of resource allocation, whilst we have robust methods for resource allocation and health technology assessment applied at the national level, this does not always translate into the local level, where there's often a lack of transparency and accountability in relation to resource management, resulting in what has often been called a postcode lottery, as there are often inequalities in access to certain services, as eligibility criteria vary across local commissioning bodies, essentially providing a variation in the benefits package provided by the NHS at the local level.
Increases in life expectancy have stalled, and we perform poorly in comparison to other high-income countries in relation to important health outcomes, including survival from common cancers, cardiovascular disease, and infant mortality. Treatment continues to be prioritized over prevention, with funding for public health continuing to decrease relative to NHS funding. Significant inequalities in life expectancy and healthy life expectancy persist between and within UK constituent countries and among different population groups classified by deprivation and ethnicity. Despite numerous efforts to increase responsiveness, the NHS has failed to fundamentally change the way in which it works with patients. And in many instances, care delivered remains too paternalistic and not focused on the patient perspective.
The Commission report includes 7 overarching recommendations covering broad issues, including funding, resource allocation, workforce, prevention, diagnosis, health information technology, and integration.
Each recommendation is supplemented by a series of sub-recommendations, specific actions, and proposed organisations responsible for implementation. We're going to give you an overview of the recommendations now, but encourage you to read our report for more detail regarding these specific actions and the organisations responsible.
So in terms of funding, there is consensus among projections undertaken by the Health Foundation, Institute of Fiscal Studies, and Institute of Public Policy Research prior to the pandemic that funding for the NHS and social care needs to increase by at least 4% per year on average in real terms to meet demand, address growing waiting lists, and make improvements to services. So in line with these projections, the Commission makes the recommendation that the government should make a long-term commitment that funding for the NHS, social care and public health increases by at least 4% per annum in real terms until 2030. So this will stop us lagging behind many other high-income countries which already spend a much higher proportion of their GDP on health. So alongside this long-term funding commitment, we also recommend an immediate injection of public funds for 2 reasons. So first, to implement long overdue reforms to the social care funding model recommended by the Dilnot Commission, which would improve financial protection, and also to reverse real-term cuts in the public health budget. In total, these increase health spending by approximately 100 billion in real terms by 2030-31. So whilst this is a substantial increase in funding, we argue that the only fair and sustainable way to implement these recommendations is broad-based and progressive general taxation. So we estimate that by 2025-26, income tax, national insurance contributions, and VAT would all need to increase by a penny. By 2030-31, income tax and national insurance would have to increase by a further penny with no further increases in VAT. The Commission doesn't just consider what funding is needed, but also how it's spent. So we argue that resource allocation can be improved at all levels, whether it's national, local, or treatment level. So whilst national level resource allocation was highlighted as a strength of the UK health and care systems, we argue that it could be improved with independent analysis of health and care workforce and resource needs to inform spending reviews, which have significant implications for the funding levels of the NHS. So we argue this independent analysis is needed because approximately 2/3 of health spending is on the workforce, and this isn't always necessarily taken into account during spending reviews. At the local level, we argue that frameworks should be developed and applied that encompass the principles of equity and efficiency. In practice, this would incorporate public involvement in decision making. And in doing so, this would improve transparency and accountability in financial planning. At the treatment level, we argue for a more structured approach to not just investment, but also disinvestment in low value care, which has limited evidence of clinical or cost effectiveness. In terms of the workforce, we argue each UK country should ensure that their long-term workforce strategies focus on optimizing skill mix to meet changing health needs and prioritizing the health and well-being of staff and informal carers as a key strategy to improve recruitment and retention. As there is freedom of movement of healthcare professionals around the UK and shared educational and regulatory standards, we argue these strategies should be underpinned by UK-wide workforce planning that is tackled at the cross-professional level. This will be challenging to ensure cooperation between each UK country. And inevitably, this is going to require investment in improving the consistent data collection of the workforce levels in each country. But this is a crucial enabler to ensuring workforce planning is tied into funding plans. We argue that to appropriately reward staff for their efforts during the pandemic, that pay must at least keep pace with average earnings. In our accompanying workforce paper, we demonstrate that only by implementing our funding recommendations can keep pace with average earnings and ensure that there is adequate growth in the workforce. If funding doesn't increase to these levels, then pay freezes are likely to be required to sustain workforce growth.
With respect to population health and prevention of disease, we argue that there should be a renewed focus on prevention and health promotion within NHS and among relevant sectors, taking a whole systems approach to prevention. Each UK country should have an earmarked fund for preventative activities and evaluate the return on these investments. Recognising the importance of action beyond the NHS, we argue that each country should develop and implement a cross-government strategy to promote health, well-being and equity in all public policies. In relation to pandemic and emergency preparedness, we recommend that structures and processes for consultation and coordination between UK constituent countries should be clarified and strengthened. More broadly, a public inquiry should be launched into the UK government's response to COVID-19.
The UK continues to lag behind in cancer survival, partly because of delayed diagnosis. So we make a series of recommendations to improve diagnosis. Crucially, we say these apply to situations where there is evidence to support early diagnosis. They're focused around improving outcomes by increasing availability of diagnostics, testing new routes to diagnosis, and targeting high-risk populations, particularly the vulnerable and less advantaged, who may have low uptake of screening, for example. This will require significant capital investment to address the UK's comparatively poor stocks of diagnostics, such as CT and MRI scanners. Throughout this recommendation, we are conscious of balancing the risks of under and over-diagnosis, which can be harmful in itself, and argue efforts to improve diagnosis must include a more comprehensive professional and public dialogue regarding the uncertainty, risk and benefit of testing and screening.
Our recommendations on health information technology focus on developing and implementing the organisational culture, infrastructure and capability to become a UK-wide learning, health and care system. This will require strengthening health information technology and data science leadership to ensure that data generated as a byproduct of care is more routinely used to continually improve the quality of services. Throughout our commission, we identify a number of data needs for the UK health and care systems, such as improved linkage of data sets, standardised collection of workforce data across the UK, and comprehensive ethnicity data across the health and care system. To map current data and establish how they can be improved and to share learning across the UK countries, which is currently hampered, we recommend developing and maintaining a UK-wide long-term data and statistics strategy for health and care. Alongside this, we argue that research efforts should be rebalanced towards supporting health services research. There's approximately £4 billion spent on health research in the UK each year, and currently only 6% towards health services research. Finally, and importantly, we argue that as part of the efforts to strengthen health information technology and develop patient-focused health and care systems, that the UK countries must deliver on commitments to give patient access to electronic personal health records, and that these are accessible across the health and care system. Finally, UK countries are currently at different stages of travel towards delivering an integrated health and care system. We argue against large-scale structural reform, as past experience has taught us that this is often counterproductive and can disrupt hard established links between sectors at a local level. Instead, we argue as a series of system barriers can be removed that currently limit integration. The government currently proposed to remove the requirement to promote competition in England, but barriers include a lack of investment in primary care, a lack of metrics to monitor quality of integration and research to establish effective integration policies, and a lack of sharing data between health and care providers. We also propose that provider reimbursement could be reformed to ensure that incentives are aligned with integration, and suggest a series of options to trial and evaluate, including offering all GPs NHS employment contracts. These efforts should support an ultimate goal that by 2030, all countries should have created single public sector entities at the local level, which have responsibility to manage budgets and organise health and care for geographically defined populations. As new organisations have developed, we argue that it's important to clarify and strengthen mechanisms that ensure public accountability, particularly as in the past this has been lacking, with many commissioning bodies granted significant powers to determine and plan access to care, resulting in the aforementioned postcode lottery, and with few mechanisms for the public to be able to challenge these decisions.
The COVID-19 pandemic has brought the enduring strengths and weaknesses of the NHS and the wider health and care system into sharp focus. The NHS remains one of the major achievements of the UK, but the future is uncertain. And longer term, we must strive for an innovative and resilient health and care system and achieve outcomes for all citizens that align with being the 5th largest economy in the world. Central to the argument of our Commission is that an ongoing increase in funding for the NHS, social care and public health is needed. Committing to increased investment in the NHS, social care and public health to the levels we set will be challenging. But in the wake of this pandemic and Brexit, much like in the late 40s, when the NHS was established, the UK will face a once-in-a-generation opportunity to invest in the health of all its population to secure the long-term future of our health system.
While the COVID-19 pandemic will force a rethink of public finance and public debt management, we believe the proposed changes to taxation to fund NHS are achievable. The UK has a lower tax burden than many comparable high-income countries, and public support to pay more tax to improve health and social care is high. Tax levels to fund public health and the NHS healthcare benefits are, after all, a social choice. Any decision not to increase funding risks the UK falling further behind other countries in terms of health outcomes, continued deterioration in service provision, and a weakened NHS to meet future major health threats. Like previous generations, the NHS exists under our custodianship, and we have a responsibility to current and future generations to secure its long-term survival. So those are the main recommendations that we've made and the perspectives that we've given.
Thank you very much to Michael for the key messages in the recommendation. It's a pleasure to introduce 4X to discuss the key themes from the Commission, and we'll hear from these speakers sequentially. I'd like to introduce Professor Anita Charlesworth from the Health Foundation to talk about NHS funding, Professor Martin Knapp from LSE on social care funding, Professor Jill McLeod-Clark from the University of Southampton on workforce, and Professor Sir Mike Richards from LSE on diagnosis. Over to you, Professor Charlesworth.
Thank you. Can I have the first slide, please? Thank you. So I'm going to give a bit more detail and rationale for the recommendations that the Commission has made in relation to funding. And the first thing that I think is really important to emphasise is that NHS funding has been protected from the full force of austerity over the last decade, and that is welcome in a time of great economic challenge. But whilst it's protected from the full force of austerity, having more funding is not the same as having enough funding. And what we see is that healthcare funding through this last decade, whilst it kept pace with the growth in the population and the fact that the population was aging, there was very little left after that for the other needs and pressures that the NHS face. So the blue line, if you see there, is broadly flat over this decade. That means little or no funding to meet pressures from a rising burden of chronic conditions, and in particular the rise of multi-morbidity and frailty in old age. Also, very critically, little funding to implement medical technologies and innovation, which are at the heart of improving quality and outcomes from the health service. And little funding to meet the totally appropriate funding pressure to ensure that real earnings for those who work in the NHS keep pace with earnings across our economy. Next slide, please. While funding is important, what really matters is what that funding buys in terms of the physical capacity and resources that you have in your system. And so whilst funding hasn't kept pace, what we see here is that has resulted in some real issues in terms of the practical resources that are available to deliver care to the UK population. So if we think about that in terms of the beds per thousand of population, scanners represented here by MRI machines, which are really important for diagnostics, and then the staff, particularly skilled clinical staff, and here we're looking at nurses and doctors. The UK is at or towards the bottom of the league table across leading European and G7 nations. So we run our system incredibly hot at the edge of capacity in the good times, with no slack then in the system at all to deal with unanticipated shocks. And COVID obviously is the biggest shock that any system has had to face this century and since the NHS was founded. Next slide, please. So against that backdrop, we recommend that now, coming out of COVID, we need to make sure not just that there's enough resources in the NHS to keep up with ongoing demographic change and population increases, but that actually we need to provide enough funding to face up to the frailties that Richard Horton talked about at the beginning here, to provide enough funding to begin to modernise our NHS, to deal with the known fault lines in our system. And that's capacity, unmet health need, as well, issues around public health, and as Martin Knapp will come on to talk about, issues in our social care system as well. That funding needs to be sustained. This is not a short-term injection of cash and then we're back to some kind of normal. And the level of funding that we're talking about, based on a range of studies that have looked at this question, is at least 4% a year. Now, 4% a year might seem an enormous sum of money, especially given the economic damage that has been reaped by COVID. But I think we need to remember that in the 70-year history of the NHS, funding has increased by 3.7% a year. And the NHS was founded at the end of the Second World War, when the country was on its knees. And yet that generation had the vision and the boldness and the determination to see that that was the time to put right fault lines in our welfare state and create a comprehensive national health service. Our challenge now is to live up to that scale of ambition then. We argue that because this is a sustained increase in funding, it's really important that we do think carefully about where the money comes from. Over recent decades, NHS funding has increased at a faster rate, not just than our economy, but also than other public services. And it has often been received funding increases to some extent at the expense of other public services. We argue that we've reached the limit of that and actually may well have gone beyond the limit. And that's important for health, because there's no point in funding an NHS but not funding the services that are really critical to the social determinants of health. So the only way we think that really we can deliver sustained increases in health service funding is through progressive general taxation. Thank you. Next slide, please. Doing that would begin to bring the UK into line with other major developed countries. And I think it's important to recognise here that whilst the scale of funding here is huge, many other countries have seen increases on this rate, and we would not be out of line with other successful economies in the level of spending that would arise if our recommendation was accepted. Next slide, please. So the level of taxation that we're suggesting is significant. We would see spending across NHS, social care and public health grow by 3.1% of GDP out to 2030-31. And that would have to be funded through increases across the major taxes, which is income tax, national insurance and VAT. And we argue for that to be staged with increases in the middle of this decade and at the end of the decade. Next slide, please. So whilst that would be a significant departure for the UK, it would actually not leave us as any sort of outlier in terms of our tax to GDP ratio when we compare ourselves to other comparable countries. And I think one thing that COVID has shown us is that arguments which pit health against wealth are false. This is a really false dichotomy. Yeah? That for the health of the nation, we need economic success. But for economic success, we need a resilient healthcare system and a population with good underlying health. So spending here should not be seen simply as a drain on the public purse. We need to shift the paradigm and see this as an investment in our social welfare, in our economic prosperity and our health. Thank you.
Thank you, Nita. So I'm going to talk a bit about now the social care recommendations from the Commission. Just to remind you, social care includes social work, personal care and practical support. And also just to remind you that arrangements for accessing care and for how it is paid vary across the UK quite a lot, and certainly much more variation in social care arrangements than in the NHS across the UK. Now, the primary purpose of the social care system is actually not to support the NHS. It is to improve the well-being of people who, for various reasons, need support in the activities of daily living. These may be people with intellectual disabilities, with physical or sensory disabilities, with long-term mental health issues, with age-related needs, and so on. And there are also many carers of people with those needs who are supported within our social care systems. Now, most people who have social care needs also have considerable healthcare needs. And so most will also have lots of contact with the NHS. So improving the way that we identify and respond to social care needs has enormous potential to reduce pressure on the NHS. And similarly, a better resourced, better functioning NHS could reduce pressures on our social care system. So those are some of the reasons why the Commission included some aspects of social care within its discussions, particularly linked to funding and workforce. Next slide, please. So this slide is similar to the one that Anita showed you, but now focuses on social care. The background to this is we've seen significant growth in social care needs in recent decades, especially because of aging, but spending has not kept up. So unlike the healthcare picture, the equivalent one, if you look at the blue line, which is the spending on social care, real social care spending adjusted for age, given the demographic trends in the population, we've seen a decrease in real spending over the past decade. Next slide, please. Now, colleagues in the centre in which I'm based, the Care Policy and Evaluation Centre at LSE, formerly PSSRU, they've done lots of analysis of future projections of spending that it would be needed to meet social care needs. And these figures are here, have been adapted by the IFS. And what they show is if you just to maintain the current system of social care, we would need an annual growth of 3.9% in real terms over that period to 2033-34. But the current system we have is itself generating lots of dissatisfaction. And we put some bullet points there which indicate some of those areas which clearly do need some attention in changing the way in which we deliver social care services. We need to increase the choice that people have. We need to increase the availability of support in communities rather than people moving into care homes all the time. We need to address this very fragile provider market because most providers are in the private sector. There are workforce issues and so on, a whole range of things. Now, one of those challenges relates to what individual people need to pay for their care. Next slide, please. So what we recommended in the Commission is some changes to the way in which social care is funded. Now, as I said earlier, the system for paying for social care does vary quite a lot across the UK, and some of these things here relate specifically to England. So one recommendation relates to this capital means test threshold, which unpacking that, it's what assets are you allowed to hold before you have to start paying for your own social care. And at the moment in England, those assets are £23,250. We recommend an increase of that floor, if you like, to £100,000. So you shouldn't have to pay for your own care until you reach that level of asset holding. Similarly, we make a recommendation about what is the maximum you should pay. And in our recommendations, we follow the recommendations from the Dilnot Commission a few years ago. There should be a cap on care costs of £75,000. We recommend that public spending on social care should not fall relative to health spending over the future years. And in particular, the last bullet there, that funding increases of at least 4% annually on average for the next 10 years will be necessary just to provide better financial protection. Next slide, please. Now, even with the substantial growth in funding we recommend, there will still be heavy reliance on carers. Carers are spouses, family members, friends who are providing support for individuals without being paid. They're not in the paid workforce. It's estimated there are currently 7 million carers in the UK, and many of those people are under huge pressure, providing very, very long hours of support each day. What we've done in my research centre is to make projections of the future availability and future need for unpaid care. And in that slide, the top two lines in purple and grey indicate projected demand, if you like, for unpaid care. If we take today's arrangements for getting support, what would be the expected need for continuing support from carers over that period of 2035? And then the bottom three lines in green, blue and black are different projections of the availability of supply of those carers under different assumptions. And what you can see is a widening gap in the need for unpaid care and the availability of carers. So at the same time as we're needing to find additional funding for the, if you like, the formal social care system, there's also a need to do something about the unpaid care informal system. Next slide, please. And there are things that we can do. This slide summarizes in those 3 bullet points some of the, well, actually the main interventions for which we have evidence that they work in supporting carers. One is in terms of providing support, indirect support. So if we provide people with social care needs with services, state-funded or maybe privately funded services, that considerably reduces the pressures, the mental health challenges and so on that carers will experience. Secondly, we can directly support carers through psychological therapy, through training, through educational interventions, through support groups. Those things work too. And for those carers that are looking to be in the paid workforce, flexible employment conditions can make a big difference to their ability to continue to be carers. And as we put at the bottom of the slide there, those interventions look to be cost effective by reference to the standard threshold that NICE would use for judging technologies. So in summary, we recommend a well-funded, restructured, responsive social care system, both to meet the health and well-being needs of a large number of people and to help to improve the NHS. Thank you very much.
Thank you, Martin. I'm going to focus on the healthcare workforce. The costs associated with maintaining the current workforce account for over 60% of the total NHS expenditure. It's clearly crucial that this workforce is fit for purpose, value for money, and has the capacity and skills to deliver effective and high quality care. Alas, there's ample evidence to suggest that something has gone wrong with workforce strategies and planning over the past decade and more. So action should now be taken in order to ensure that the future workforce is indeed fit for purpose and sustainable. Next slide, please. Action will include a stocktake of capacity in terms of staff numbers, as we've already recognised in previous presentations. But most importantly, it will involve taking a radical look at types of roles and the skills mix required, both now and in the future. These roles and the composition of teams must be designed to meet growing demands for care, as well as being able to respond to increasing complexity and changes in patterns of health and care demand need. Future workforce plans also need to be based on the best ways to optimise efficiency and effectiveness. And prevailing culture has to be one which is inclusive, which tangibly values and supports staff, and which, as a result, enhances morale and, most importantly, retention. But there's compelling evidence that these issues do now need to be addressed. Next slide, please. You'll recognise this slide. We now know the UK has fallen seriously behind other high-income countries on several measures, but notably here in terms of the numbers of physicians, nurses, and indeed other health professions who are not represented on this slide. We can see where we stand in the nursing league table on the left, and the right-hand column shows where we are in terms of physicians, and clearly we're very near the bottom. Next slide, please. The NHS needs a workforce which can respond to changing patterns of healthcare need. However, this slide illustrates a paradox. In spite of policy moves to shift care closer to home, as well as, for example, respond to the escalating demands for mental health care, the current skills mix in nursing does not reflect these needs. The overall numbers of nurses has more or less flatlined over the past decade. However, the numbers working in the community or as health visitors and the numbers supporting those with mental health or learning disability needs have dropped significantly. These drops are shown in the below 0% lines on the graph. There has been a small growth in adult care numbers, but the only real growth has been in children's nurses, which is the top line, the grey line of the graph. Ironically, most of these, again, work in acute hospital settings. Next slide, please. The same kind of picture emerges when you look at the ratio of hospital consultants, GPs, with clear growth in the number of consultants and with GP numbers stagnating. It really is difficult to reconcile these nurse and physician data with being able to support a policy of providing care closer to home and, in the case of nursing, to meet the increasing care needs of those with mental health problems. Next slide, please. So this workforce situation is clearly not sustainable. The Commission therefore recommends that workforce strategies and plans are urgently revisited and collaboratively across the UK. These plans must be developed on a multi-professional basis, not in professional silos, as has happened in the past. Future plans will need to challenge traditional role boundaries. If the growing and changing demands for care are to be met, the benefits of new roles, task shifting, and extended practice must be maximised. Future plans will also really have to concentrate on the huge impact of technology on the ways in which healthcare is being delivered. So this in turn, of course, will involve education reform, because we will need to change the way we educate existing roles and people in existing roles and those in new roles. And we need a culture which will tangibly show that the NHS values and is investing in its staff, and that it's equitable and inclusive. Of course, this will require greater investment. We need to sustain growth, keep pace with average earnings, and create a fit-for-purpose, cost-effective future workforce. The main message, though, is that this investment in the workforce must be wise. More of the same will not provide the public with the support they require to meet future healthcare needs. Thank you.
Thank you, Jill, very much. I want to talk a little bit about diagnosis. I think it is widely recognised that accurate and timely diagnosis is critical to achieving optimal outcomes across a whole range of conditions and diseases. And can I move on to the next slide, please? Here I'm showing the comparative survival rates for cancers, largely focusing on cancer because that's where we have the best international comparative data, but I believe this is also true for other conditions as well. And as you can see, for colon cancer, top left, the UK or Great Britain figures there, the worst that you can see on this graph, well behind the EU15 and the G7. Breast cancer, slightly better picture there, possibly because we've got a very good screening program for breast cancer, and we have made efforts over the last 10-15 years to narrow the gap in survival between ourselves and other countries. Prostate cancer really is difficult to evaluate, so I won't say more about that because it really depends how much PSA testing you do, as is shown by the high survival levels in the USA. But lung cancer, again, we do very poorly, and only just ahead of Finland there and well behind the EU15 and the G7. So we've got poor cancer survival rates, and there is increasing compelling evidence that at least part of that is due to late diagnosis. And then on top of that, within the UK, there are persistent inequalities in health outcomes and between different population groups. Next slide, please. So what needs to happen? We undoubtedly need to increase a capital investment and on top of that to optimize skill mix, both in primary and secondary care and among our diagnosticians to address this unmet need for diagnostics. You've already seen the slide from Anita that shows that in terms of CT scanning and MRI scanning, we are at the bottom end of the OECD league table in terms of numbers of scanners. To reach the average for the OECD, we need to double the number of CT scans that we do each year in this country. And those are needed for a whole range of different conditions: cancer, heart disease, respiratory disease, you name it, we need better CT scanning and MRI for that matter as well. But on top of the investment that we do need to do things differently. We need novel diagnostics, we need different routes to diagnosis to be developed, but they also need to be rigorously tested so that we can then make sure we give cost-effective treatments that will change outcomes for individuals. And as has already been mentioned, we do need a comprehensive dialogue with both the professionals and with the public to encourage dialogue about understanding uncertainty, risk, the benefit of testing and screening. It should just be said that the public in this country are more worried about wasting their GPs' time than those in other countries, and GPs in this country are less likely to investigate or refer than those in other countries. Next slide, please. So here is a model that the Commission has developed for a new vision for diagnosis. I'll briefly mention the different components. AI over on the left will have its place both in identifying patients at high risk of different conditions, but also in image analysis that's already being used for looking at the retina, and it's also being used in chest radiography, mammography, for example, and will be much more widely used. But that's not to say that that's going to replace the need for radiologists and pathologists. That's not the case. We certainly need continual evaluation of what we're doing in terms of diagnosis. We need to make sure that that is accompanied by the comprehensive professional and public dialogue that I've already mentioned. In primary care, in the middle there, we need to make sure that we increase the availability of diagnostics to primary care clinicians with point of care testing when that's been properly evaluated. And we also need to make sure that we make the best use of pharmacists and others in the community. In secondary care, we undoubtedly need this capital investment in the equipment and facilities. We need an increase in the diagnostic workforce, but combining that with a major skill mix initiatives, as Jill has mentioned. And then we need to do things differently again. At the moment, almost all of our diagnostics is done in the acute sector. What we are now proposing are community diagnostic hubs halfway between primary and secondary care so that all have access to those. And on the right-hand side, let's remember that there are inequalities in diagnosis as well as in treatment, and we need to work with others to make sure that we rectify those, but we need to do that through co-production. Thank you very much indeed.
Thank you very much to Anita, Martin, Jill and Mike for those excellent presentations that just expand on some of our recommendations a bit. We're going to move now to our first panel, which focuses on the UK perspective. A really important part of the Commission was that we did take a UK-wide perspective to understand learning from the important differences in the systems in each country, but also some of the commonality of the strengths and challenges across the countries. It didn't make the Commission a simpler task, but it did add to value, I think, in terms of our analysis and in the recommendations we were able to come up with. And I'm really delighted today that we've been joined by three of our commissioners who will give a view from Northern Ireland, Scotland and Wales. These commissioners bring extensive experience in terms of research, frontline experience and health board managed experience to the discussion. So we have Professor Kieran O'Neill, health economist from the School of Medicine, Dentistry and Biomedical Sciences at Queen's University Belfast, Professor Moira White, Head of College of Medicine and Veterinary Medicine, and Sir John Crofton, Professor of Respiratory Medicine at the University of Edinburgh, and Professor Marcus Longley, Professor of Applied Health Policy at University of South Wales, Cardiff. So just to explain, each member is going to give a brief response to the Commission and what we've heard to date so far. We're going to hold any Q&A for the end of today if we do have time. So Kieran, can I ask you first to give your perspective from Northern Ireland?
Thanks, Emma. Thanks, Emma. I'm not sure if I'm coming on screen. Okay.
Yes, you are, Kieran. On you go.
Okay, thanks. So the apologies for the delay in starting. The recommendations in the report resonate within Northern Ireland. Indeed, efforts to address some of the issues reflected in our recommendations are already underway. In April, the Health Minister announced funding for 1,300 new nursing and midwifery places, for example, to help to begin to address a shortfall in staffing where 1 in 10 of our nursing posts are currently vacant. As was noted by him and officials in the Department of Health, however, such investments must be sustained and this will require funding to be increased and placed on a longer term footing to facilitate strategic planning than has existed in the past. Indeed, it has been reported that in Northern Ireland, we will require an approximately 6% increase in funding to stand still, let alone to address the longest waiting times for secondary care of any part of the UK. Importantly, in Northern Ireland, efforts to address recognised issues in care provision will also require political consensus and stability. Our Assembly only emerged from a 3-year suspension 1 month before being buffeted by COVID-19. And that was the 5th suspension since its creation in December 1999. To progress the change, we will need to see in our health service, there will need to be a readiness to put the long-term common good above what might be seen as short-term, narrow, hardy political interests. Hopefully, we'll see these conditions prevail in the years ahead and our health service be able to respond positively to the recommendations in the report. Thank you.
Thank you very much, Kieran. That really gave an insight into the common but the unique challenges in Northern Ireland as well. Moira, I wondered if I could go to you next for a perspective from Scotland.
So good afternoon. So as people have already highlighted, we have a great opportunity in the UK to compare the different models of NHS care in the 4 nations and to learn from best practice wherever it's found. Scotland's NHS faces a number of challenges both in the post-COVID recovery phase and beyond. Health inequalities here are a major issue, with men and women living in the least deprived areas of Scotland likely to live 13 and 17 years longer respectively in good health than those in the most deprived places. And an emphasis on health improvement is more important than ever if we're to tackle avoidable risk factors. And minimum alcohol pricing is a recent example where Scotland has decided to take a different approach from the rest of the UK. Positive developments here include extension of free school meals and work to further integrate health and social care. But we need to do much more to tackle the underlying causes of health inequalities if Scotland's to fulfil its potential and become a healthier society. Scotland's model of integrated health and social care has much to recommend it, but is still a work in progress. And we must learn from the challenges faced by the care home sector during the COVID-19 pandemic in Scotland and elsewhere. There's a need to increase resource for this sector going forward and to progress its integration and better alignment with the NHS. As you've already heard, a long-term strategy to optimise the skill mix and to prioritise the health and well-being of care staff is urgently needed to ensure that we have the right people in the right numbers to deliver excellent care to our frail elderly. Scotland's Integrated Health and Social Care Workforce Plan, published in 2019, is a start towards this goal. And the needs of our older population are a crucial area for research into better understanding of the causes and consequences of frailty and multimorbidity, and harnessing the expertise of engineers, computer scientists, and others to support independent living in the community. And finally, there's a need for effective and integrated workforce planning more widely that is part of an effective UK-wide strategy, but also addresses local needs, including in Scotland, the delivery of healthcare to our remote and rural regions, which remains a challenge.
Thank you very much, Moira, and for such a comprehensive answer in such a little time. Thank you. I wonder now if I could pass to Marcus finally to give a view from Wales.
Thanks very much, Emma. Delighted to do this. Like my colleagues, I think the recommendations are equally applicable in Wales, despite the differences in the systems between the different countries. For those of you who aren't aware, Wales is a region with a population of about 3 million to the west of England, and will of course be proud to say that we actually invented the NHS in Wales, I have to say that. So the COVID-19 pandemic has hit normal services in Wales as elsewhere for 6. And waiting times for all but the most urgent services are now worryingly high and getting worse by the week. Staff, I think, are weary and looking for a break. There are many patients who are still reluctant to seek help, and the health service is desperately trying to invent new ways of meeting need in this short window that we've got as we come out of the COVID pandemic. So all of that, I think, is the immediate legacy of COVID-19 for Wales. But of course, all of that piles up on top of a series of longer term systemic challenges, which the Commission's report highlights. So the health and social care system, and particularly, as we've heard from Martin Knapp just now, the social care Cinderella, has been chronically under-resourced and undervalued in Wales, probably as elsewhere, for many years, and is now facing what I think is amounting to an existential challenge as the cracks become really quite significant. There is a need to build a new health and social care workforce, as we've heard, fit for the future, and really importantly, to co-produce with the population of Wales a more efficient service, and one which concentrates more on adding value than it does on being busy. I think in this challenge, Wales has several advantages as it hopefully adopts the recommendations of the Commission. Several advantages. Health and social care, I think, are close and generally work quite well together in Wales. The NHS is phenomenally popular and supported. It isn't being undermined at all by political debate or other influences. And there is in Wales a very strong tradition of a communitarian solidarity, which is, I think, also very helpful for the future. And a country that I think is probably big enough to make change happen whilst still being small enough to understand what's needed. So all of this is really important and necessary, but clearly not sufficient, as many of the most important public health challenges in Wales really have barely improved in the last generation. There are a couple of other reasons to be positive, I think. Prudent healthcare is an approach adopted in Wales a few years ago, which is absolutely about adding value and investing resources where they will return the most dividend for patients. And we also have a statutory basis in Wales in the Future Generations Act, which requires public bodies to think about the welfare of the next generation whilst dealing with today's challenges. So the hope is, I hope, that the shock of the COVID-19 pandemic will jolt the system into addressing these challenges and adopting the recommendations of the Commission. And this afternoon, as we're talking, we're actually awaiting the results of the Senedd election. So we will see which political leaders we're going to have for the next 5 years in a matter of a few hours. Thanks, Emma.
Thank you very much. Thank you to Kieran, Marcus and Moira. We've only had a brief chance today, but I hope something that comes out of the Commission is that we more routinely think about the lessons that we can draw on from each country. In the interest of time, I'm now going to pass over to Alistair Maguire and panel 2. Thank you.
Thanks very much, Emma. We now are going to attempt to answer some of the questions, a few of the questions. So we've got a panel which consists of some of the other commissioners, Professor Carol Brain, who's Professor of Public Health and Primary Care at Cambridge University, Professor Azim Majid, who's Professor of Primary Care and Public Health at Imperial College London, Professor Mike Drummond, who's a health economist from the University of York, Professor Aziz Sheikh, who's Director of the Usher Institute at the University of Edinburgh, and Professor Angela Coulter, who's affiliated to the University of Oxford. Before we get on to those questions, or these Q&As, I want to give the chance to Nigel Edwards, who's the Chief Executive of the Nuffield Trust, an independent health policy think tank, who has a long and distinguished career in the NHS as a manager, both at the hospital and the regional level. And I want to give Nigel a chance to give some reflections on the Commission's report. So over to you, Nigel.
Thanks, Ali. It's really hard to disagree with this very deep and excellent analysis, and I would endorse all of the conclusions that we've heard presented here, and urge people to look at the report in more detail. I think, however, the next Lancet Commission in this area might want to ask the question: well, why is it that we have got ourselves into this situation? Now, obviously, the context in which we're embedded, the high levels of health of income inequalities in the UK certainly explain some of this. But I think we have some very serious issues about governance and the way that the politics and oversight of our system works as well. We certainly seem to have a nervousness in dealing with those inequalities, or to take aggressive public health action, at least in England. But we've also, I think, got a fairly big problem with short-termism, and therefore a lack of real willingness to engage in a health in all policies approach. At least, again, this is much more true in England than it is in Scotland and in Wales in particular. The history of the NHS, where it's born from, the political debates about who is in control that markets start, are still really with us today. And it is really noticeable for those of us who do lots of work with other healthcare systems, the extent to which the NHS is really very centralised. And indeed, other NHS type systems really do not try and operate at the level of centralisation that we've seen particularly in the English context. The devolved administrations obviously are smaller countries and therefore are closer to the action, but some of them have their own political culture, which maybe creates a similar dynamic of overly engaged and entangled politicians who are overly fond of reorganisation, and the combination of scale and complexity with centralisation and the absence of a really good theory of change. We've seen over the last 30 years an extraordinary laboratory of almost every single policy instrument in the policymakers' toolbox, apart from co-payment, used to try and to make change happen. I can't help think that the idea of increasing tax is going to run into the problems, because I do trace a number of these issues that I've mentioned here back to the role of the Treasury, its short-termism, its lack of willingness to invest for the long term, which leaves us with little headroom for investment in new technologies, for example, and nervousness about capital investment. It's not just diagnostic equipment in which we fall behind. If you visit hospitals in Scandinavia or France or Germany and look at the quality of the building, same is true in primary care. We've still got a lot of primary care in people's homes. We have not got a culture of long-term investment, of creating headroom. At the micro level of the healthcare system, I think that culture I've described has meant that we've not done enough to harness the clinical talent, the dynamic created by professionalism to drive improvement. But we've also perhaps not sufficiently questioned the 1948 settlement, which split primary care from secondary care and operated a gatekeeping model. And I think we welcome the move towards integration, but too much of that integration is still focused on the structures and not enough on how the clinicians work together. And it's that focus on structures that has been one of the banes of my life in the NHS, and shows no signs of abating. So in summary, less politics, more long-termism, more focus on change and people, and less on structures and processes. Over to you, Ali.
Thanks very much, Nigel. A very nice summary of some of the problems that we face. I'm going to ask each of our panel members now one question that has been raised by the audience. And if you can be very concise in your answers, that would help a lot before handing over to Julian Legrand at the end to wrap up. So could we start with Carol? Carol, there's a question from Ronald Marchant who asks, essentially, how effective can preemptive activities or preventative measures in the healthcare is how I read that, be, and how can we as citizens take these preemptive measures more seriously? What's your thoughts on that, Carol? You're on mute, I think. Yeah.
Yes, so this is about the balance of upstream prevention, early detection, and then mitigation once somebody has an illness or a combination of illnesses and things which interfere with their daily lives. And it's quite clear that investment in public health activities, and that they will be well beyond the boundaries of the health system, and that's very, very important. That investment makes a major difference. And it's one of the reasons why, for example, that post-war investment into the whole population that Anita mentioned has led to a reduction in dementia as an outcome at any given age in our UK populations and in other countries across the world. So we have good evidence that upstream prevention is really effective. But we also have to look at the role of screening and early detection, and also the treatments. And we have to think about the choosing wisely or prudent healthcare, as has just been mentioned, and getting that balance. And I think it's absolutely critical. The cross-governmental working is essential for the primary prevention and the reduction in inequalities, and plays a part in the other parts. But what's really important in this balance is to have a dialogue with society and with the public about what investments make what differences, when and where, to which populations, current populations and future generations. I hope that's quick enough for you.
Yeah, no, thanks very much. I'll move straight on to Azim to ask about the workforce. And essentially, there's been a couple of questions about how to ensure we get the appropriate skill mix, and also given the idea that we have competing interests and from other sectors of the economy, how do we pool the workforce together into the NHS? And also, how do we not just push them all into the front line, but also make sure we have adequate support for them? What's your thoughts on that, Azim?
Thank you, Alistair. I think the report has made clear that the NHS faces very stark workforce shortages in key areas like mental health, general practice, nursing, diagnostic, which need to be addressed. Those can't be addressed very quickly, so we need a short, medium and long-term plan to address those issues. I think in the short term, we need to make the roles attractive, improve retention. We need to really look hard at the work that our frontline clinical staff do to try to take away low-value tasks, and also provide them with adequate admin support. So you'll find that quite a large amount of time of frontline staff is actually spent on low-value administrative tasks, which can be either computerized or done by non-medical or non-nursing or non-clinical staff. So I think that's very important. Skill mix is also very important as well. We need to really look, I think, at new groups of workers, community health workers for primary care, healthcare assistants in hospital settings, staff who can take on a lot of routine tasks such as measuring, clinical variables like blood pressure, height, weight, routine monitoring of patients. That will also take a burden off frontline staff as well. But that will take some time to do. So it's going to take a long time to actually increase recruitment and really put in place this changes in skill mix and support for frontline staff. For the short term, we've got to really work very hard at retaining staff we've got, making those roles attractive and trying to really support them as much as we can. We've also need to look at data science as well. So data science is very important. The NHS is now moving towards a system in which data is used increasingly to support clinical care, measure quality, drive innovation. And so we've also got to recruit those people as well, compete with the universities, industry, etc. So those roles also need to be attractive as well. Need to be made rewarding, so that people have defined career pathways, career progression, and the opportunity to contribute to research and innovation and feel they're benefiting public health in the UK.
Thank you very much for that, Azim. I'll come to Mike Drummond next. There's a question about, essentially, we've been very successful, as we raise in the report, that in terms of health technology assessment, the use of NICE and SMC, for example. How do you see this health technology assessment evolving as personalized medicine becomes more important?
Yeah, thanks, Ali. Well, one of the areas we did identify in the report was that the system had been stretched a bit by entry of high-cost technologies. And We have quite a few important new technologies coming through, particularly gene therapy, which is very much targeted at the individual and transformational for some patients, but also a very high cost. And I think that we probably need to have a more strategic response to these new therapies, looking not only at how we evaluate them, but how we would be able to afford them given the current constraints, particularly when there's often a big upfront cost and a benefit stretching over many years. And one of the things we did say in the report was that although HTA had been really well conducted in the UK, we could perhaps get even more strength from it by pooling our resources across the 4 nations in the same way as the EU had done on a much broader level amongst European countries.
Okay, thank you. Aziz, could I turn to you now? And we've had some questions which relate to some of the answer that Azim gave, but it was asking about how will medical education manage to get budding medics interested in the use of large quantities of big data, and how can we stimulate the use of big data generally in the management of the NHS going forward?
Yeah, thanks, Ali. So good to see everybody. So I think there are absolutely enormous opportunities here, like Azim has mentioned, using these data at all levels within the system to think about planning, prioritization, service delivery, and personalization of care. What that does need is a cadre of trained individuals, so we can think about selection criteria when bright young things are entering into medical schools, for example, training provision whilst they're at medical school. But I think we need to think about this in the entire learning arc. So what opportunities are there in postgraduate education, for example, and are we training up our leadership, the CIOs, the CCIOs, those in the C-suite on NHS leadership boards? So I think absolutely enormous opportunities. We're really only at the beginning of this, but what it does need is career paths to be created. And I think just picking up on one of the other questions, Ali, we need to be competitive. The NHS can't compete with the salaries offered by industry, but I think there is plenty of opportunity to think about creative partnership models where individuals have hybrid careers or they're moving between sectors. So they're bringing some of those benefits that they're acquiring in industry to the NHS, and then going back into industry maybe and taking an understanding of the domain. Thanks.
That certainly fits with the idea of this new work-life balance, moving towards secondments and changing your working environment. And of course, one of the recommendations is to improve the working environment within the NHS for the staff. But could I turn to Angela now and ask you, Angela, about patient engagement? One of the questions that came in is that's critical to the delivery of the NHS. But have we done enough to ensure patient engagement, and how can we improve it? You're on mute just now, Angela. Sorry.
This is a key issue, and I don't think we should let people go away thinking that healthcare is only delivered by health professionals, because of course patients often do the major part of the job, and for that they need support, and particularly those in the most vulnerable groups. And we have seen some of that, but not nearly enough as yet. We need things like sharing information, sharing decisions, supporting self-care, involving local people in policy developments and so on. Shared decision-making needs to become the norm, and the evidence shows it leads to better decisions and fewer unnecessary and unwanted interventions, which is going to be particularly important since the pandemic has left us with a massive backlog of care needs. We also argue in the report that as a tool, giving patients the tools to do this job should include giving them control over their own medical records, because that could help. And again, there's evidence to support this. That could help improve communications and ultimately reduce dependence and lead to better, more effective self-care and better health outcomes.
Okay, thank you all very much. I'm sorry I've had to curtail the Q&A a little bit because of time, but certainly I'd encourage all of our audience to read the full Commission report, obviously, and the background working papers. There were 5 of those published by the Lancet as well. They're all published today. You can access them through the Lancet website. So I'd just like to thank everybody involved in the presentation today. And for some closing remarks, I'd like to hand over to my colleague and friend, Julian Legrand. Julian's got a long history of academic work in healthcare and of course policy work through being advisor to the Tony Blair government along with Simon Stevens on the NHS. So Julian, over to you to wrap this session up. Thanks very much.
Thank you very much indeed, Alistair. I think that there are two reasons why this report is particularly timely, and both, unsurprisingly, arise from the pandemic. As several speakers have pointed out, the pandemic has brought out both the strengths and the fault lines in our health system. But I also think that it's had an even more fundamental effect. I've been working on economics of health policy, as Alistair mentioned. I've now been doing it for over 40 years, longer than I care to remember. And much of that time has been arguing about what you might call the social contract with respect to the NHS. That social contract, that contract which was essentially that we will all pay our taxes without fuss and bother, and in return we'll get a health service that will give us all the healthcare that we want, or indeed more profoundly that we need. And pre-pandemic, I think that contract was fraying, as the report has pointed out. So there was increasing waiting lists, poor health outcomes, as Mike Richards was saying, inadequate resources, as well detailed in the report. However, I think the pandemic has actually given the contract, if you'll forgive me, a shot in the arm, both literally and metaphorically. The rhetoric of NHS, the rhetoric of NHS heroes, the reality of NHS heroes, the public perception of the immense amount of work and trouble that has gone in to providing to dealing with the pandemic, and of course the success of the vaccine program. And all of this, in some senses, gives us a golden opportunity to strengthen the social contract with respect to healthcare by, as the report puts very well, improving its resource base in various ways, and even more importantly, to extend the social contract, extend it particularly to social care, as Martin Knapp was eloquently arguing. So I think we should welcome the report as a major contribution to the deepening and the extension of the social contract, and thus really to provide a tax-funded health and social care service that actually is the envy of the world. Thank you.
On that, I'd just like to thank everybody once again and close the session. Thank you very much.